We have an intense stack of medical sources for our deep dive today.
Covering pediatric and general emergency medicine, plus critical care and anesthesia.
And our mission today is to examine the microscopic, frantic supply chain running constantly inside you. The system that delivers oxygen and blood to your tissues.
Because when that system works, it's a miracle. But when it fails, things go bad very quickly.
Exactly. We're looking at how the body maintains this critical flow and what doctors actually do when they have to step in and manually override a failing human system. So, okay, let's unpack this by starting at the very top. We have to look at the ultimate resource hog, which is the brain.
Oh, absolutely. I mean, the brain has massive metabolic demands. It requires a constant, uninterrupted supply of oxygen and glucose.
Right.
But it also exists in a highly restrictive physical environment, which makes treating injuries there incredibly treacherous.
Yeah. Reading through the section on intracranial dynamics, I just couldn't help but picture the skull as that hard shell suitcase. Like when you're an infant, your skull actually has a lot of cartilage, right?
Yeah, it functions almost like a soft-sided duffel bag. It has a little bit of give to it.
But as you age, those centers ossify. They turn into this rigid bone vault. And inside that vault, you have exactly three things.
Just three.
Right. Brain tissue taking up about 85% of the space, blood, and cerebrospinal fluid.
Which creates a totally closed system. Any change in volume inside that rigid box has immediate mechanical consequences.
So if you try to overpack a hard shell suitcase, the zipper just breaks. What happens in the skull when swelling or bleeding occurs?
Well, initially, the brain tries some clever compensatory tricks. It wants to avoid bursting that proverbial zipper.
Make space, basically.
Exactly. If swelling or a bleed adds volume, the brain physically squeezes some of its cerebrospinal fluid out. It pushes it down into the spinal canal.
Wow.
It can also decrease the amount of venous blood returning to the heart just to buy a tiny bit more room.
But those mechanisms have a limit, I assume.
A very strict limit. Once those are exhausted, you hit a rigid wall. Even a microscopic increase in volume leads to a massive, clinically meaningful spike in intracranial pressure.
And if the pressure inside the skull keeps rising, the fresh oxygenated blood rushing up from the heart, it physically cannot push its way in against that resistance, right?
Right. The tissue starts to starve. And the physical result of this unchecked pressure is a terrifying process. It's called cerebral herniation.
Herniation. That sounds awful.
It is. Because the skull is a rigid vault, there is only one exit, the foramen magnum.
That's the hole at the base of the skull, right?
Yeah.
Where the spinal cord exits.
Exactly. When the pressure gets too high, the brain is literally shoved downward into that hole. It physically crushes the brainstem.
Oh my.
Yeah, it is a devastating event, and it becomes irreversible in minutes.
This actually directly connects to a really chilling detail in the text, the talk and die scenario.
Yes, often seen with an epidural hematoma.
Right, so you have a child who falls off their bike, hits their head, and they seem completely fine. They're awake, they're talking, alert, and then suddenly they just deteriorate and collapse.
The talk and die phenomenon perfectly illustrates why emergency physicians are trained to be so hypervigilant. The initial impact might not even severely disrupt the brain tissue itself.
But it tears a blood vessel.
Exactly. Usually an artery, like the middle meningeal artery. So blood is pumping into that closed hard shell suitcase, forming a hematoma.
But the kid is still talking.
Because those compensatory mechanisms we mentioned are actively shifting fluid to make room. The child is awake because the brain is managing it. But the very second those mechanisms max out,
the pressure just skyrockets.
Exponentially.
Yeah.
And herniation begins almost instantly.
That is so scary. Because a doctor doesn't have, like, a pressure gauge on the child's forehead. They have to read the systemic signs. What are the red flags they look for?
The sources highlight Cushing's triad as the ultimate red flag for impending herniation. That's severe hypertension, bradycardia, and irregular respirations.
High blood pressure, slow heart rate, and weird breathing. The mechanics of this are just fascinating to me. The body realizes the brain is starving because of the high pressure, so it radically jacks up the systemic blood pressure to force blood into the skull.
It is a desperate, massive sympathetic nervous system response. The body clamps down on blood vessels everywhere else to shoot the blood pressure up to extreme levels.
But there's a catch, right?
A huge mechanical catch. You have baroreceptors in your carotid arteries that monitor blood pressure. They sense this dangerously high pressure and send emergency signals to the brainstem.
telling the heart to slow down.
Exactly, via the vagus nerve. So you end up with soaring blood pressure combined with a strangely slow, thumping heart rate.
And the breathing.
The physical squishing of the brainstem disrupts the respiratory centers, causing the erratic breathing. Another critical warning sign is anisocoria.
That's the pupil dilation, right?
Yeah, one pupil suddenly dilates and stays wide open because the cranial nerve controlling the eye is literally being stretched over the edge of the herniating brain.
Wow. And when you hit that point, the medical interventions read like doctors turning into frantic mechanics. The first-tier therapies are entirely about manipulating physics.
They really are. They immediately elevate the head of the bed to let gravity help drain blood from the venous system.
And they initiate controlled hyperventilation, which blew my mind. The reasoning there is wild.
Oh, it's brilliant.
Blowing off carbon dioxide actually changes the pH of the blood, right? Which causes the blood vessels in the brain to constrict. Shrinking the physical diameter of those vessels reduces the volume of blood inside the skull just enough to buy precious millimeters of space.
It's a total race to manipulate biology. Perhaps the most aggressive intervention, though, is the use of hypertonic saline or mannitol.
Pushing intensely salty fluid directly into the veins.
Yes. If we connect this to the bigger picture of osmosis, water always naturally flows toward a saltier environment. By making the bloodstream hyperconcentrated with sodium, the blood effectively acts like a chemical sponge.
So it literally draws water out of the swollen brain tissue.
Exactly. It pulls it across the blood-brain barrier and flushes it out through the kidneys. It's a brilliant physiological hack to lower intracranial pressure.
True. But despite all of that, I mean, the hyperventilation, the hypertonic saline, or even surgically removing a massive piece of the skull in a craniectomy to physically give the brain room to swell, sometimes the primary injuries are simply too devastating.
Right. And that brings us to a profoundly sensitive area covered heavily in the critical care sources, the concept of brain death.
Yeah. Because when we traditionally think of death, we picture a heart stopping.
But modern critical care has totally changed that. Utilizing advanced mechanical ventilators and powerful vasoactive medications, we can sustain a beating heart and inflating lungs long after the brain itself has been completely and irreversibly destroyed.
The sources use the Uniform Termination of Death Act as the framework here. It defines brain death as the irreversible cessation of all functions of the entire brain, including the brainstem.
What's fascinating here is how absolute this diagnostic criteria must be. It's not a coma,
Right.
nor is it a persistent vegetative state where the brainstem still manages basic autonomous functions. It is complete biological death, legally and clinically accepted as such.
I have to say, I put myself in the shoes of someone standing in an ICU room facing this. Wait, how can a family accept that a loved one is gone if their chest is still rising on a ventilator, their heart is beating, and their skin is warm?
It's incredibly jarring. It creates this profound cognitive dissonance for families, and that leads to completely understandable objections on religious, cultural, or emotional grounds.
Because their senses are telling them the person is alive.
Yes, but the visual cues of life are being artificially manufactured by machines. This difficult reality is precisely why the medical threshold for declaring brain death is staggeringly high. It requires a rigorous, exhaustive clinical evaluation that leaves absolutely zero room for ambiguity.
The sources outline a strict requirement to rule out confounders before even checking reflexes. You have to prove the lack of brain function isn't just a temporary suppression.
Exactly. The clinical team must eliminate any external factor that could mimic brain death.
Like what?
Well, if a patient is severely hypothermic, their brain's metabolic demand drops so low that neurological function effectively pauses. Massive metabolic imbalances or the presence of sedating drugs like barbiturates can do the same thing.
So the doctors have to warm the patient, correct the chemistry, and wait for medications to clear completely.
They have to. And once those confounders are cleared and there are no brainstem reflexes, no pupillary response to light, no gag reflex, no reaction to pain, they move to the definitive evaluation. The apnea test.
The apnea test.
Yeah.
Apnea translates to the absence of breathing.
Right. It's the ultimate, undeniable proof of brainstem failure. In a functioning human body, the primary trigger to take a breath is actually not a lack of oxygen.
Really? I always thought it was.
Most people do, but it's actually the buildup of carbon dioxide in the blood. Receptors in the brainstem monitor this constantly. So to test this, doctors pre-oxygenate the patient with 100% oxygen to keep the organs safe.
And then they just temporarily disconnect the mechanical ventilator.
Yes. They stand at the bedside, drawing arterial blood gases, and watch the carbon dioxide number climb.
The normal baseline for carbon dioxide in the blood, the PaLeo2, is around 40 millimeters of mercury. They allow the CO2 to build up past 60 millimeters of mercury, or at least 20 points above the patient's baseline.
And in a living brainstem, this highly toxic, acidic chemical environment would absolutely force an involuntary gasping breath.
But if the CO2 hits those extreme thresholds and the chest remains perfectly still,
Then the brainstem is definitively destroyed. It is a stark, heavy reality, underscoring just how vital that constant flow of oxygen truly is.
we have been examining the brain at the absolute point of no return. But let's pull back. Consider what happens when that loss of flow is just a momentary blip. The brain is structurally fine, but it briefly loses its supply. The sources cover this under syncope.
Syncope is a sudden, transient loss of consciousness caused by acute global cerebral hypoperfusion. Basically, a temporary drop in blood flow to the entire brain.
Fainting, essentially. But the practical diagnostic challenge outlined in the text is differentiating syncope from a seizure. To a bystander, a person suddenly collapsing to the floor can look identical.
It can, but the underlying mechanics are vastly different, and the clinical features diverge based on those mechanics. In syncope, the blood literally drains away from the head.
So what does that look like?
A hallmark sign is extreme pallor. The patient turns pale and ashen. They typically experience a long prodrome, feeling dizzy, nauseous, or seeing spots before collapsing.
And then what happens when they hit the ground?
Crucially, once they are horizontal on the ground, gravity allows blood to rush back to the brain. They regain consciousness rapidly and are completely lucid.
A seizure, conversely, is an uncontrolled electrical storm in the brain. Rather than turning pale, a seizing patient often exhibits cyanosis.
Turning blue.
Right, turning blue around the lips because the electrical storm disrupts their breathing muscles. You see rhythmic jerking, and afterward they enter a postictal state.
Yeah, the brain is profoundly exhausted from the electrical misfires. It leaves the patient deeply confused, agitated, or somnolent for tens of minutes or even hours.
Distinguishing between the two dictates the entire treatment path. Most syncope is just a benign vasovagal response, right?
Yeah, standing up too fast, seeing a needle, triggering a vagal nerve reflex that drops the blood pressure. But emergency physicians actively hunt for massive red flags.
The sources emphatically highlight exertional syncope or supine syncope. If you pass out while playing sports or while lying completely flat on your back, it isn't just gravity or a mild nerve response.
No, that is a massive red flag. It strongly suggests a life-threatening structural heart defect or a lethal arrhythmia where the heart's electrical system suddenly fails to pump. Those patients require an immediate ECG.
And this raises an important question about the body's intricate autonomic regulation, particularly when facing gravity. And here's where it gets really interesting.
Oh, I know where you're going with this.
The text details postural tachycardia syndrome, or POTS, a condition defined by an inability to manage the mechanics of standing up. This is so relatable for a lot of people.
It really is. When a healthy person stands, gravity naturally yanks a massive volume of blood down into the lower extremities and the splanchnic bed. That's the vast network of blood vessels in the abdomen.
So normally your autonomic nervous system senses this sudden downward shift instantly. It releases a surge of norepinephrine, signaling the blood vessels in your legs and abdomen to constrict aggressively.
Right. This active squeezing pushes the blood back upward against gravity. It maintains a steady flow to the heart and brain. But in a patient with POTS, that autonomic squeezing mechanism is dysfunctional.
The blood just drops into the legs and pools there. The vessels fail to constrict effectively, and the brain realizes its oxygen supply is plummeting.
The body enters a state of sympathetic panic. The brain sends an emergency overdrive signal to the heart, demanding it beat drastically faster to compensate for the lack of returning blood volume.
The clinical criteria for POTS is a heart rate that skyrockets by more than 40 beats per minute in children, or 30 beats per minute in adults, within 10 minutes of simply standing up.
But the blood pressure usually remains totally normal.
Which is wild. The heart is racing at 140 beats per minute while the person is just standing still at a grocery line. They experience intense lightheadedness, crippling brain fog, and nausea.
Because it is a mechanical plumbing issue mixed with nervous system dysfunction?
And the fixes are counterintuitive, right? The text says it isn't primarily about taking medications. It requires extreme lifestyle modification.
Yes. Patients are instructed to drink upward of 80 ounces of fluid daily and consume massive quantities of sodium, sometimes swallowing literal salt capsules.
Which sounds crazy until you understand the osmosis.
Exactly. We return to the systemic power of osmosis. Salt inherently retains water. By ingesting massive volumes of salt and water, you artificially expand the patient's entire physical blood volume.
You're just overfilling the physiological pipes.
So completely that even when gravity pulls a large portion of the blood downward, there is still enough residual volume at the top of the system to keep the brain adequately perfused. It shuts off the heart's panic response.
They also prescribe progressive recumbent aerobic exercise. Think rowing machines or recumbent bicycles. Because if a POTS patient tries to jog,
Gravity pulls the blood down, their heart rate spikes to 180, and they crash.
right. But by exercising in a seated or lying position, you completely remove gravity from the mechanical equation. This allows them to build cardiovascular muscle tone and increase physical blood volume over months. You're fundamentally training their vascular system to tolerate being upright.
It perfectly illustrates how localized pooling can be managed by manipulating the whole system.
Well, let's scale that concept up then. We just talked about a localized plumbing failure when standing up. What happens when the entire body's plumbing network fails simultaneously and does not bounce back?
That brings us to our final critical topic, shock.
People often use the word to describe an emotional reaction, like being shocked by news. But in the emergency department, shock is a mechanical crisis.
It is the acute, life-threatening failure of the circulatory system to deliver adequate oxygen to the tissues.
The critical care chapters outline 5 distinct categories of shock, and I think it really helps to envision the human circulatory system as a city's water supply. The tissues and organs are the houses requiring a constant pressurized flow of oxygenated water to survive.
I like that analogy. It makes the physical failures really obvious.
Okay, so scenario 1. The city's main reservoir has a massive leak and runs completely dry. There simply isn't enough water in the system to pump.
That aligns perfectly with hypovolemic shock, caused by massive traumatic hemorrhage or profound dehydration from severe vomiting. The reservoir is dry.
Right. Scenario 2. The reservoir is full, but the central pumping station breaks down. The water is there, but the mechanical force to push it forward is gone.
This is cardiogenic shock, occurring during a massive myocardial infarction, a heart attack, or severe heart failure where the heart muscle simply fails.
Okay, what if the water is there and the pump works, but a boulder falls onto the main line, a physical blockage in the pipes?
That is obstructive shock. You see this with a massive pulmonary embolism, which is a blood clot lodging in the lungs, or cardiac tamponade, where fluid fills the rigid sac around the heart, physically suffocating its ability to expand and pump.
Scenario 4 is where the infrastructure itself fundamentally changes. The pump works, the water volume is adequate, but suddenly every single pipe in the city dilates. They double in width, and the pipe walls become porous, linking water into the ground.
The systemic pressure drops to near zero. That's distributive shock.
And there's also a 5th one, right? Dissociative shock.
Yes. Dissociative is where the water is flowing, but it's completely toxic or useless to the houses, like carbon monoxide poisoning or severe anemia.
The text dedicates massive real estate to distributive shock, specifically focusing on sepsis. How does a bacterial infection cause the body's entire pipe network to suddenly dilate and leak?
It's a catastrophic inflammatory cascade. When a severe infection enters the bloodstream, the immune system mounts a defense. But in sepsis, that immune response becomes violently unregulated.
The body basically turns on itself.
Exactly. White blood cells release a flood of inflammatory mediators, primarily cytokines and nitric oxide.
And nitric oxide is a potent vasodilator, right?
Very potent. It directly attacks the smooth muscle lining the blood vessels, forcing them to relax wide open. Simultaneously, the cytokines damage the endothelial lining, causing capillary leak syndrome.
So the blood volume is literally seeping out of the circulatory system into the surrounding tissues. The vessels are fully dilated, so the systemic vascular resistance just plummets.
The heart is frantically pumping, but it is pumping against empty space.
The sources detail a fascinating clinical presentation here, noting patients can exhibit cold shock or warm shock. What's the difference?
This reflects the body's desperate physiological battle. In cold shock, the body is still attempting to maintain core blood pressure by aggressively clamping down the peripheral vessels in the arms and legs.
Right, so the patient's skin is ice cold, clammy, and their pulses are barely palpable.
Exactly. But in warm shock, the inflammatory vasodilation completely overrides the body's defenses. The patient is flushed, their skin is bizarrely warm to the touch, and their pulses are bounding because all vascular resistance has been obliterated.
And the treatment algorithms for pediatric septic shock dictate a frantic, minute-by-minute battle. You have a golden hour to reverse the freefall. If the pipes are dilated and leaking, the immediate reflex is aggressive fluid resuscitation to refill the system.
The sources describe a push-pull syringe technique used on children.
Yeah, that sounded intense. Instead of relying on gravity from an IV bag, clinicians attach a massive syringe, draw fluid from the bag, and physically slam it directly into the patient's veins.
Pushing up to 60 milliliters per kilogram of fluid in under an hour. They are simultaneously administering broad-spectrum antibiotics to destroy the bacteria fueling the rogue immune response.
But if you push massive volumes of fluid and the blood pressure continues to crash, you enter fluid refractory shock,
And that requires the immediate deployment of vasoactive medications.
bringing out the heavy chemical artillery like epinephrine or norepinephrine.
These are profoundly powerful pressors. If the immune system's nitric oxide has forced the blood vessels to relax, continuous intravenous epinephrine targets the alpha-adrenergic receptors on the blood vessels.
Chemically commanding them to clamp tightly shut.
Exactly. It artificially recreates systemic resistance, keeping the system pressurized so blood can actually reach the brain and vital organs.
It is the ultimate manual override of a collapsing biological system. I mean, we have journeyed from the closed, highly pressurized vault of the brain and the stark, absolute thresholds of brain death.
Through the gravity-battling complexities of POTS.
And finally into the systemic full-body collapse of shock.
Reviewing these mechanisms, from manipulating osmotic gradients with salt to artificially squeezing blood vessels with epinephrine, it truly underscores just how magnificent yet exquisitely fragile the human machine is.
So what does this all mean for you, listening to this deep dive?
It demonstrates that human survival is dictated by one absolute necessity: the uninterrupted delivery of oxygen. Modern critical care is essentially a high-stakes balancing act of chemistry and physics, with medical professionals actively manipulating fluid dynamics and vascular resistance just to keep the biological engine running when its automated sensors fail.
We spent this whole deep dive looking at how doctors act as master mechanics, manually forcing the body's failing systems to work. It really makes you wonder, as medical technology continues to advance, will we eventually engineer entirely artificial systems that bypass these fragile biological pumps and porous pipes altogether, permanently solving the mechanical problem of blood flow?
That is a fascinating thought.
Something to mull over. But until then, keep drinking your fluids and stand up slowly.